So, what is the association between fasting and cancer, particularly prostate cancer? Well, today's conversation is with one of the leading experts on the field, Dr. Valter Longo. Talk about Longo. It took a really long time to get Dr. Longo on this podcast, but here we have him. Dr. Longo is a leading biogeneral ontologist and expert in aging, fasting, and nutrition. He serves as professor of gerontology and biological sciences at USC and directs the Longevity Institute, along with oncology and longevity program in Milan, Italy. Known for his pioneering work on fasting mimicking diet, Dr. Longo's research shows how periodic fasting can influence aging, metabolic health, and immunity. He's the author of the best-selling book, The Longevity Diet, and founded the Create Cures Foundation to promote health and longevity through accessible, nutrition-based solutions. What a great conversation is around fasting. Fasting is something that I practice, I've done. I do a fasting mimicking diet. I recommend many of our patients to do FMD, fasting mimicking diet, for several reasons. And we discuss it at a very basic level. What is fasting? What are we trying to accomplish? We discuss some of his research around it, which is fascinating, as to the metabolic benefits of fasting. And then we go into what are the possible benefits with fasting and fasting mimicking diet and cancer and prostate cancer with science, not just what we think would happen. So enjoy this conversation on a very important topic, which is fasting. When you're in cancer therapy, it's like, well, eat more, make sure to eat more calories. Well, do we have it wrong? So this is a good one with Dr. Valter Longo on fasting and cancer. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Gio Prostate Podcast. This is your host, Dr. Gio, and we're aiming to optimize your overall health, certainly prostate health, male health, but how about overall health? How about longevity? How about living better with age as men? Well, who better else than Dr. Valter Longo? Valter, I almost feel like a kid who's meeting like some sort of athlete, their favorite athletes. Like if I were to meet like Michael Jordan, I would just feel like, a little giddy and awkward because, my God, I've been following your work for so long. The longevity diet, fasting mimicking diet, which I'm actually on day 5 right now, drinking my fasting mimicking tea. And I'm so impressed with you and the amount of work that you've put into really the field of longevity. So I thank you for taking time out to be on the podcast.
Oh, thank you. Thank you for having me.
Well, earlier today, I was like, all right, where do I start? I mean, I don't want to have, this is not the Joe Rogan podcast. We don't do 3 hours here, although I can do 6 hours with you. So I said, all right, where do I go with Dr. Longo here? Let's start with this. My first question, most fundamental question, particularly you and your line of work, is why put so much emphasis into longevity and then into fasting? And I'll tell you a little story. I learned about fasting during my naturopathic medicine training over 20 years ago. I read this book by Arnold Arett on fasting. This is a book from the late 1900s. I just fell in love. I was like, wow, this concept, very little science at the time, but this was just his findings and what sort of made sense to this particular author. Part of the history of naturopathic medicine includes fasting. That's part of the nature cure history of naturopathic medicine. Includes fasting, includes hydrotherapy, which now people are doing cold plunges and things like that. And I always felt that was, and I started fasting at the time. There was no kind of FMD. I started doing water fast, maybe 2 to 3 days, 2 to 3 days, maybe every 2 to 3 months, one full day a week, etc., kind of experimenting. And I tell you, I felt better. I never did 21 days. I know that people do 21 days and so forth. When later on, fast forward to, I don't know, several years ago when I started doing fasting mimicking, I was like, wow, this is great because I can work. I can still work. What I was doing back then when I'm doing water fast, I didn't have kids. I didn't really have a job. I was a student. So if I had to take a nap, take a nap. So what triggered you to look into longevity, and what triggered you to say, look, there's something here, however many years ago you started, let's do some research around fasting and longevity.
Yeah, so I always show these slides and I start with the risk factors for cardiovascular disease and Alzheimer and cancer. And you see obesity and smoking, right? So obesity and smoking are the top risk factor. And then I show the next slide and I show obesity and smoking compared to 30 years of aging, and they disappear, right? So obesity and smoking disappear as a risk for cardiovascular disease, cancer, and Alzheimer compared to 30 years of age. There's so little that, that you cannot even see them. So so that's why that answers the question why longevity, right? It's just like that's it. If you can treat only one thing, treat aging. Almost everybody is 20 years old is perfectly healthy. They're not doing. They could have a terrible diet and smoke, but they're 20 and they're still very healthy. So then that answer that. And then fasting. I hate the word fasting, and I think it's doing as much damage as it's doing good. Because it's used as a word, right? It's like doesn't mean anything, right? So what are we talking about, right? And who are we talking about? So I think now we're seeing what I knew was going to happen. We're seeing the anti-fasting movement, right? So there's a fasting movement, and now we're starting to develop the anti-fasting movement. Right. And because people are saying, rightly so, there's a lot of problems, right? And if you don't pay attention, fasting can cause a lot of problems. And so, for example, in a recent review that I wrote for Cell Metabolism, we talk about, if you do intermittent fasting, let's say quick fasting, one day on, one day off, and then you do chemotherapy while you're refeeding, that can actually increase damage, right? Whereas doing fasting before chemotherapy for 3 or 4 days and don't refeed until 2 days after chemotherapy, that's very beneficial. So the devil is in the detail, right? So It goes from increased cardiotoxicity to extreme reduction of cardiotoxicity based on how you do the fasting, right? So I think that I started with fasting in my first year in graduate school at UCLA, and I started starving bacteria, and then I starved yeast, and then I starved mice, and I starved people. And I was working with Roy Walford, that was one of the world pioneers in calorie restriction. And so I think that I moved away from calorie restriction, which was just a reduction of calorie intake, and into fasting, because I saw that if I completely starve organisms, they live longer and they became much stronger. And then we started looking at the genetics of aging, and then realizing that most of the genes that control aging in these simple organisms had to do with sugars, had to do with proteins, with amino acids, and the removal of it, right? So the more you block the pathways that were activated by sugars and amino acids, the longer the organism lived. And then the ultimate experiment was around 30 years ago. It was a double genetic mutation plus fasting. So mutation in the sugar pathway, genetic mutation in the protein pathway, and then fasting, and the yeast lived 10 times longer, right? So there's a complete reprogramming of their lifespan from 6 days to 60 days.
And so what then, for you I did research at Columbia University. We talked about that before we started recording, and I just didn't like that part of my life. I didn't like writing for grants. I didn't like, I like implementing the research. I certainly didn't like doing the research. And particularly when research on diet, it was very difficult. Controlling variables, right? So if you do any diet, how do you control all the variables? How do you control the fact that those in the controlled group are not eating what they're supposed to eat, or vice versa, whatever the case may be? When did you start your first trial in humans, and what was that first trial about? What was that process like for you?
The first trial was a long time ago with cancer patients, and this was at Norris Cancer Center at USC. And it was water-only fasting trial, so that we asked the oncologist at Norris, asked the patients to undergo 2 to 3 days of water-only fast. And we realized that was a disaster because the patient did not want to do water-only fasting, and the oncologists were worried. So everybody was worried.
I'm
And
surprised it was IRB approved.
yeah, it took a while. It took a while, but
Right.
eventually we had such a strong data in water-only fasting in mice that they approved it. And but there was no problems. I mean, the patients eventually did fairly well, but nobody wanted to do it. They felt like they were cheated. So yeah, you're giving me water. Is that's your treatment? And so yeah, and they struggled. I mean, I've done water-only fasting one time in my life. I still remember every day of it. So yeah, so there was something psychologically very, very difficult about water only fasting. It doesn't mean you've done it, I've done it. Lots of people do it. It doesn't mean it cannot be done. It just means that probably for 95% of the population, that's not something that they can do regularly.
Particularly in an uncontrolled environment. I think that if you're in a fasting clinic of some sort where you're being supervised, but on your own, it used to be that they called when you started feeling poorly, they called it a healing crisis. And then the more intelligent people at the time thought of it as, wait a minute, this is probably more than a healing. This is probably a crisis, not a healing crisis. So I think in a controlled environment, in a clinic of some sort, it's probably a better approach. What was the outcome of that study?
The outcome was pretty good, meaning it was sort of preliminary, but it was 1, 2, or 3 days of water only fasting. And you started seeing the 3 days of water only fasting being associated with less side effects from chemotherapy in the patients and versus the one. So the comparison was one versus three. And so already 3 days, we started seeing some indication of improvements. It was too small to come up with any statistically valid, but yeah, look promising. But that was about it, right? And then we did a couple of studies like that. Then everybody around the world moved to the fasting mimicking diet for cancer treatment.
So then so if they fasted 3 days, on day three they receive chemo of their fast.
They received chemo on day 3
And
or on day 2. I forgot whether
on
yeah
day two.
they do
So
it.
the longer they fasted while doing chemo, the better they did versus 1 day of fast and then do chemo. Is that right? More or less.
Yes.
And and we're going to get into the FMD in a second in your current research, but I'm curious because I think look, sometimes studies are low powered, but they give you guidelines, even if they're low powered. It's very difficult, very expensive to do big studies. So I value, underpowered studies and their conclusions and outcomes either way, if it's positive or negative. So so just to be clear, because I know that some people are going to listen to this and say, "Oh, well, I'm doing chemo. Let me get this fasting thing right." If they do one day of fasting and then do chemo, the outcomes were not as great versus 2 days of fasting and then chemo, or 3 days of fasting and then chemo, more or
No,
less.
yeah, again, it was not statistically significant, but there seemed to be like the people that did 3 days of water only fasting, they seem to be doing better. Yeah.
Sure.
And then the ones that did one, right? That was the where we
Right.
started seeing differences between 1 and 3. Yeah.
And what's your guess? Is it the fact that they are in ketosis on day three, and maybe there's a benefit there as it relates to the being more sensitive, the cancer cells being more sensitive to the chemo? What would be your sense as to why that is?
No, well, this trial did not look at cancer, right? So
So,
this trial
okay,
was just side effects from chemotherapy,
right, got it.
and of course now also for safety reasons we don't
Right.
recommend water only fasting to anybody. I mean, water only fasting, some people get hypoglycemia,
Yeah,
hypotension,
yeah,
and people have to keep in mind that 10%, if it was not 1 out of 10, it's still a lot of people, right? And so and also keep in mind that it could be 1 out of 3 after you do 10 cycles, right?
mm,
But of course, if 1 out of 3 people after 10 cycles, within 10 cycles, they're going to get a major side effect, that's a problem, right? And that's
Sure.
why we moved away. And and the fasting mimicking diet has salts in it, and of course calories and reserved carbohydrates and or reserved carbon sources, etc.
Let's
But
move. When
yeah,
did the
so
fasting mimicking diet then come about? That initial. So you were saying at some point there's something to this fasting, but I'm not sure that a full water fast is the way to go. And then you started tinkering perhaps with, okay, maybe this amount of food, that's too much. What was the thinking behind it that led to, I think, is a revolution with FMD right now?
well, I mean, we were pretty sure that, I mean, seeing the problems with the clinical trial, and by the way, not expecting the trouble, because our reasoning when we sat down with the oncologist back in was, oh, they're going to do it, they're going to be motivated, they're going to do it, and that wasn't the case, right? And we at that time we were not even thinking about side effects, right? Because we were just thinking, do it or not. But then we started thinking, as I published books and I started getting feedback, then that's where I started hearing, hey, people that do water only fasting at home, they can have a lot of big problems. Yeah. So, but then I think it was we went to the government, right? So we went to the National Cancer Institute and National Institute on Aging, and they both sponsored, give us a lot of funds actually. And we still get funds for it today. So for the past, whatever, 20, 15 years or so, we've got a lot of funding, or 20 years or so, we got a lot of funding to do research on fasting and develop fasting mimicking diet. So then the first application to the NCI was, let us develop a dietary program that patients can do, and they'll get the benefits of water only fasting without having to do water only fasting. Of course, we were experts in how does fasting change the level of different genes and different pathways, and so we knew exactly what a fasting response was. And so so then the ketone bodies, the glucose, the growth factors, the growth factor binding protein. So we were looking at all of that. We had ways to measure a full fasting response. And so eventually we developed a fasting mimicking diet. This was a low calorie, low sugar, low protein, high fat, plant-based, 4 to 7 day dietary program.
And so how do you, because I look at it now, it's like, yeah, it's low, it's low in protein. I would have thought that you cannot reach those results, those biological results, without an actual fast. Like any amount of calorie would be a problem. So clearly you said, no, you can have a certain amount of calorie before a particular threshold. I don't know, 1,000 calories or less or so. How did you come to that conclusion, knowing that you can actually mimic, like the name implies, fasting and not just do a full fast to get the results?
But yeah, again, so it's not about calories, right? So we knew that you can have a high calorie diet, which will, based on the composition, respond like a 0 calorie diet for certain things, right? And not all things, but of course it's easier to do it with water only fasting, because that's a fast and everything responds as you expected. But if you do a lot of work, molecular and cellular work, then yeah, you have a pretty good idea. And this is why I was saying earlier, you can even do it genetically, right? You don't even have to change the composition at all. You can just use drugs to make certain changes. Of course, it's extremely difficult to do what fasting and fasting mimicking diet do with drugs, because it's you'll have to orchestrate lots of different things, and so it would take just an incredible amount of drugs and intervention. So, but I mean, theoretically, you could do it with drugs, right? You could add lots of things and remove lots of things, and especially master regulator, you wouldn't have to regulate components, but master regulator, right? So if you go after the master regulator, so for example, growth hormone, we know we've been following people in mice with growth hormone receptor deficiency. And so if we go, that's like the top master regulator. If you change that, it's not like fasting, but it's about 50% of the effects of fasting, right? So yeah, so then this knowledge, this cellular, molecular, and genetic knowledge allows us to to replace water only fasting with a fasting mimicking diet.
All right. So Fasting mimicking diet. Again, I've done it 4 times, I believe. I tell you what I like about it as a consumer. I certainly love the science and the amount of science behind it. Like I said, very difficult to do science around any nutritional protocol, particularly in humans. And I think that there's a lot of science around FMD. It's easy. It's really easy. I don't have to think about food for 5 days. It's only 5 days. I believe anyone can do anything for 5 days. The level of difficulty depends on many things, depend on how well my diet was before that. If I do my time restricted eating the way I should, less of a problem. If I don't follow it as much as I should, then I am more like craving foods and things like that while I'm on it. Love the foods as well, and love the fact that it's changing. By day 5, Walter, I have to say, I don't want to have soup for a long time by after day 5. I am done. I am tired of soups.
And you don't have to have soup for a long time, because the idea is to do it maybe no more than once every 3 months, right? I mean, unless you have diabetes or something that requires monthly cycles.
So I have had patients. So I working within urology, primarily prostate problems, and so patients with prostate cancer, we know when they have a higher BMI, they have a higher risk of prostate cancer, advanced prostate cancer recurrence after it gets treated, and many succumb to the disease with higher BMI compared to those that have a lower BMI. So what I do with these patients, I have them on something like FMD once a month, and then a dietary approach that we'll discuss. That's kind of until they get to their ideal goal. What are you able, and I'm aware that particularly when you have a product, you have to be very careful with the language you use around cancer. I'm very well aware of that. But what are you able to say based on the research on FMD and cancer?
I think that cancer, whereas with diabetes and weight, I think we're much more conclusive evidence, because it's just one thing, and one thing that has 3 or 4 factors. But let's say one very clear change. Let's say you reduce obesity, and then you reduce insulin resistance, A1C, and maybe inflammation, maybe cholesterol. So say 6 or 7 things, right, in cardiometabolic domain. But cancer, it's a lot of therapies and a lot of cancers, like 100 type of cancers with 1,000 type of therapies. Yeah. So it's extremely difficult to navigate. And I think what we can say is the following. So for example, the one thing that I cite the most is the 4 or 5 year survival data from Claudio Vernieri at the National Cancer Institute in Milan, because they actually look at our survival, right? So then they compare triple negative breast cancer, one of the most aggressive, most deadly cancers, most common cancers. And so for triple negative breast cancer, after 4 years or so, the overall survival was nearly doubled for patients that were doing fasting mimicking diet plus chemo versus chemo alone. So I think that's an initial fact. I mean, it was a small trial, but it's starting to show, and I think they have a follow-up trial showing data that is supportive of this, still with triple negative breast cancer. Now they have a larger trial, 150 patients, that is ongoing, and hopefully that moves it to more of a standard of care together with the standard of care, meaning like fasting mimicking diet plus whatever the standard of care is, whether it's chemo, immunotherapy, kinase inhibitor, hormone therapy, et cetera, et cetera. Yeah, so that's one or a few trials. And then there is many. We're helping lots of hospitals, including Indiana University. I think Mayo Clinic now started a trial on cancer. And so, it takes time. And but so going back to the general answer is the following. Be careful, because fasting, as I mentioned earlier, right? Let's say you do fasting, you do refeeding, and in the middle of refeeding, you have a lot of chemotherapy in your system. It could be a recipe for disaster, right? Now, why now? Because now you have quick proliferation, lots of growth factors together with the carcinogen, which is the chemo in your system. So the right way to do it is to fast and then do the chemo, wait, and then when the chemo is gone from the system, then refeed, right? But this is just one example of many problem areas that you're going to encounter. So then you have to have professionals that know what they're doing. And so we have foundation clinics in the US and in Europe. And so it's called Create Cures in the US. And so please, if anybody wants to, they can talk to our dietitians and nutrition experts.
What's it called again?
Create Cures.
Create Cures. Okay.
And please, for your clinic, if you want to collaborate with us, we would love to collaborate. Yeah, so then that's one. And then the other one is that we're saying, well, don't do it unless the oncologist and thinks that things are not looking so good, right? Like I was saying, triple negative breast cancer, metastatic triple negative breast cancer. That's, yes, then I would definitely talk to the oncologist and say, let's add it because it seems like things are not working. Standard of care alone is not working. So let's see if combined with, so I would say in any situation when the standard of care alone is not working very well and there doesn't seem to be a better option of what you're already doing, then I would talk to the oncologist about the fasting mimicking diet.
So in with my patients that are not breast cancer, but to be honest, breast cancer and prostate cancer are cousins, right? They're very similar in how they behave. So I look at breast cancer research to adopt some of that research into prostate cancer, though, even if it hasn't been proven for prostate cancer, because sometimes you're in the trenches and they need answers. So that kind of research in breast cancer is actually interesting to me. In prostate cancer, I have some patients that are very advanced that do chemo, but most of them do radiation. And I have them do radiation. I have them do fasting mimicking during radiation as well. So do you find that the benefits that one would have from chemo and FMD would also, if they would also have the same benefits or similar from radiation and FMD?
Yeah, we published that, right? We published that, I think, with glioma radiation in glioma plus or minus fasting. And so that worked very well. But there was mice, so it's hard to know. We've done a clinical trial with prostate cancer with Dr. Sullivan in Ireland, but that was mostly focused on hormone therapy and weight loss, and it worked extremely well with this group of patients, right? So they went from a higher risk level to a lower risk level. And that's what was Dr. Sullivan and we were trying to achieve. So now we're Cedars-Sinai, and together, I think with Duke and lots of other universities are doing a large trial. Did this Dr. Friedland.
Yeah, Steve Friedland. I know very well. He's a urologist. Yep.
Yeah. So they're doing a large trial in FMD and prostate cancer, and we'll see what happens. And we're doing a lot of work right now. I have 3 people that are focused on prostate cancer in the lab. So I could tell you we have some really cool, very powerful data for at least animal studies and prostate cancer involved in the fasting mimicking diet. And so what we're very excited about in the cancer domain is what we call escape pathway blockade, right? So we apply fasting mimicking diet. We get differential effects in normal cells and cancer cells. So the normal cells go in one direction, and the cancer cells go in the opposite. And then we use what's called RNA-seq or single-cell RNA-seq. So we look at how the cancer cell rewires. And eventually, we're going to be able to do this very quickly in the clinic, right? So we could take a circulating tumor cell, look at the rewiring, and then intervene. And so we're already doing that, but it's just early stages. And so now we can see how they adapt and target the adaptation pathways, right? So then, let's say we've shown for triple negative breast cancer that they adapt by activating PI3 kinase pathway. So then we use a drug, the safest drug that we can find, FDA approved, to target the PI3 kinase pathway, right? So
the ability to personalize the approach.
Yes. First, identify how let's say prostate cancer cells stay alive, and then say, they stay alive with this. And the interesting thing is we looked at now many different cancer lines. We're looking at 100 cancer lines. So there is surprisingly limited number of escape pathways, right? So it's not like there is 100,000 escape pathways. There is probably less than 50, right? So it was very good news because now there could be 50 drugs that can be used to target most of the escapers.
Fabulous. This concept of autophagy, as it relates to FMD and fasting. How real is it? Because we can't really measure it. I think we know it from animal studies. So, but how real is it? So, autophagy is this process of where natural cell death of cells, particularly cells that are not normal. Hopefully, some of those are cancer cells. How real is autophagy? And I know you're going to be very careful with your language. Well, I don't know that this cures cancer cells or causes autophagy, but what's the possibility of that actually happening from doing fasting mimicking diet or a fasting program?
Thank you for watching the Dr. Geo Prostate Podcast. Take a proactive step and improve your health and vitality with the Prolon Fasting Mimicking Diet FMD, a 5-day plant-based program developed by Dr. Valter Longo, designed to mimic the effects of fasting without the challenges. Prolon helps activate autophagy, reduce inflammation, support weight management, and promote overall longevity, all while nourishing your body. As a special thank you, you can access the Prolon kit for just $148. Use the link below to get started. Empower your journey to better health today.
Yeah, so apoptosis is the cell death, and autophagy is just a self-eating process, which does not usually, it can involve cell death, but it doesn't usually involve cell death. Yeah, so I think that for cancer, we're looking more at apoptosis and differential apoptosis, meaning that we want the cancer cells to die, to commit suicide, and the normal cells, of course, don't do that because they know very well how to deal with fasting. Now, autophagy is a little tricky because autophagy can either help or hurt the cancer, depending on which cancer. So we just published, for example, an ALL, a type of leukemia, and autophagy in that case actually helped cancer cells. So when we block autophagy, so the way we kill the cancer is by using the fasting in that cancer actually blocked autophagy. And the block of autophagy, so fasting normally activates autophagy in normal cells. But in these blood cancer cells, it blocked autophagy. So we can either block autophagy with the fasting mimicking diet or block it with chloroquine. And either way, we got the mice to be cancer free, right? So this was really remarkable effects. This is Roberta Buono in the lab that did this work, right? So, but if you forget cancer for a second, in which autophagy can be good and bad, I think that in normal now there's a group that's about to publish on fasting mimicking diet and autophagy, and I think that the data I've seen, at least, it shows that there is no autophagy all the way to day 4, but autophagy starts at the end of day 5, right at the end of the fasting mimicking diet period. That's when you start seeing evidence of autophagy, which makes sense also based on what Guido Kromer and others have done, where even after 2 or 3 days, there is really no evidence of autophagy. So people like to use this word, but it doesn't really occur for a while. So you have to push the human body to a pretty, long-term fasting period, at least, let's say 5 days to start seeing the effects.
So, and so then the program is 5 days. So can you get to that point within those 5 days, or it typically takes longer than that?
This is what the data shows. That at day 4, still nothing, and at day 5, now you start seeing the autophagy markers. Yeah.
And day 3 is when you're supposed to be more on ketosis, where you use ketones for energy around day 3, if you follow the program. Yeah, what's the benefit of that? And expand on that if you'd like.
Yeah, I mean, so ketone bodies are one of the many, I think, factors of the fasting mimicking diet effects. And so they start going up, let's say on day 2 or so, and then you're going to get into a higher level of ketosis in day 3, 4, 5. Now, the fasting mimicking diet is designed on purpose. A lot of times people say, but there's starches in there. There is like rice and
correct. And there's sugar. I had a patient who is doing it with me, and he had 2 questions. He was astute. He says, I love this. I do this all the time, but why so much sugar in these bars? There's a lot of sugar in these bars. How can I get to ketosis when there's so much sugar in these bars? So
it's not a lot of sugar.
It's not actually correct. That's what I said. Yeah,
very little sugar. But there are starches, and part of it is because we want to make it easier for people to do it. Part of it is because we want to block this very high level of ketogenesis. So we don't want people to go to 6-7 millimolar ketone bodies and back and forth because we're worried about the long-term consequences of that, right? So could it be that eventually at least a portion of people will be hurt by this, this yo-yo movement, right? Then people say, oh, you're
Overthinking.
paranoid.
Yeah.
But I don't think so, right? So I'm thinking, I don't want to think like GLP-1, right? Oh, it's okay if whatever percentage of people get optic ischemia. I mean, I don't think like that, right? I mean, that might be okay for the drug companies. It's not okay for me, right? So I think that it is designed to get you into a fasting state, get the ketone bodies up, get the autophagy eventually in day 5, but don't exaggerate with it, because you don't know what's going to happen eventually. I'd rather have a smaller effect that builds up. And this is what we see with the fasting mimicking diet. Let's say diabetes patients, after 12 cycles, 70% of them have reduced drug use, right? So it works very well, but it takes its time to work, right? And this, whatever people may have a spike of glucose, good, right? Because that spike of glucose, we're now seeing over and over and over. We're about to publish another paper on this, causing insulin resistance decrease, A1C decrease, diabetes reversal. And within a year or two, you're starting getting 15-20% of people cured, right? Meaning like in remission. It may not be permanent, but it's certainly in remission from diabetes. So I think it's, I will let the data speak for itself, and the data looks good.
Why the sodium in it? It seems, again, some people, I find it to be fine. Some said, well, these soups are high in sodium. I can taste it. Why the sodium? I know there's a reason for it.
Yeah, I mean, why the PBS in the hospital, right? The saline solution. Well, they give you saline solution because you need that sodium for your body to, your blood pressure and lots of other functions in the body. Yeah, so we don't want the patients to pass out. We don't want to become hypoglycemic, and we don't want them to become hypotense. So that's part of why the sodium is in there.
And a little flavor too, right? Because people actually have to do it. If it's too bland, that's one of the reasons. I gave those 2 reasons. That was just common sense to me. But blood pressure reasons, you give it a little flavor too, so because it's more tolerable.
Yeah, I mean, and this is interesting discussion with the FDA, right? So we started talking to the FDA, and the FDA, rightly so, because they're the FDA. They say, well, too many ingredients, too difficult, too many flavors. And I hope we'll soon go back to the FDA and say, because it's going to take a big change in the FDA to come our way. So we're saying patients don't want to have 7 ingredients, all the time, the same 7. I think the FMD now has 60 ingredients, right? Because it has to be reasonable for people to complete it, right? So it's going to be an interesting discussion with the FDA. Can we allow a new, more complex, more food-like medicine? Because otherwise, yes, we can narrow down 60 to 7, take all the taste out, and but I think people are just going to reject it, right? And they're going to say, I can't do this for 5 days. I cannot do 7 ingredients for 5 days over and over. Yeah, so I think it's an interesting, and I hope, podcast and other media help us, have a dialogue with the FDA in saying, okay, can you come more our way, right? Where it's food is medicine. Well, you need to have food as medicine. You cannot have food as a drug, and then the drug and only the drug is medicine, because it's not food anymore. It's a drug, right? It doesn't matter if it comes from food or not. It's a drug. And I mean, it's exactly what the FDA say. It's a drug to treat cancer, or to treat diabetes, but we're saying, no, it's food to treat cancer, it's to treat diabetes. And so can we come up with a compromise where we standardize it enough, but we don't force patients to go into something not feasible, right? Not feasible to have 7 ingredients for 5 or more days.
You're fighting the good fight. You're fighting the good fight, because in my profession as a naturopathic doctor, I know food is medicine. We know, but we can't really say that or promote it, or because food is not a drug. And you're fighting the good fight for the rest of us, not only for you and your company.
Yeah,
You're
by the
trying
way,
to prove or disprove, because that's what research is all about, that food is indeed medicine, or can be medicine, or can be part of medicine.
yeah, and by the way, it's not a fight because the FDA basically say we are the Food and Drug Administration, right? So they basically say if it's part of a program, let's say a lifestyle program, we allow it. We allow diabetes to be cured by a lifestyle program, right? And if the lifestyle program has a fasting mimicking diet within it, so it's not a fight with the FDA. It's more like it would be nice if it was even more standardized, because then people can get reimbursed, and there's a lot of things that come up that are not more difficult to get now. So if food became medicine to treat diabetes, for example, and it comes in a box, now people could say, yes, I could have the GLP-1, metformin, but I could have an option and get reimbursed for fasting mimicking diet, let's say, and the doctor, so that I can have a program to get me into remission versus being stuck with diabetes for the rest of my life.
Let's talk a little bit about protein. I think and diet therapy and diet approaches I've done for over 25 years, both personally and with patients. And as it relates to protein, I'm a little bit still at a loss. Why? Because there's two schools of thought. There is a school of thought that in order to maintain good metabolism, you need skeletal muscle. And there's three ways of maintaining skeletal muscle. One is exercise. The other is testosterone, hormonal. And the other one is not only protein, but those with the highest essential amino acids. And some people say, well, you need whatever, a gram per pound, or 0.7 grams per pound, or this, that, and the other. Another school of thought is, wait a minute, if you do too much protein, some of those amino acids can be pro-carcinogenic if you're not careful, and make cancer worse, or the development of cancer. I did have, hopefully it'll be published in December as well, an expert from UCLA from System, Dr. June, who is an expert on glutamine, and we had a full discussion on glutamine and prostate cancer, a type of amino acids. My question is this. I'll tell you what I do with patients, and you can say, Gio, you got it all wrong. It's okay. I'm okay. I want to get it right. What I do with patients is that, because I do believe, particularly men over 60 or any man of any age who's undergoing androgen deprivation therapy, who now they're going to have a lot of muscle wasting if they're not careful. And I don't like sarcopenia, which is muscle wasting that comes with age. I don't like it as a result of treatments. I think they end up, either the quality of life is not good, or they end up dying from other things that's not prostate cancer. So I want them to keep muscle. So I don't think they need a gram per pound, but they need about 0.7 grams per pound. Now, they can either get it from high quality animal sources in my protocols, or if you're vegetarian, let's get it from high quality. I'm not going to try to convert you to, if you're a vegetarian, to do meat, to eat meats, and I'm not going to try to convert you, if you are a meat eater, to be vegetarian. I just want you to get enough protein in, along with some level of fasting. So 12 hours or so a day. Break that down for us. Protein and health, protein, amino and amino acids, and cancer, and this concept of retaining muscle for longevity and metabolic purposes as one ages, or under ADT.
Yes. So
there's a lot there. I'm sorry, but
yeah. So I don't know that there is two schools of thought. I think that there's a lot of people talking. That's for sure.
Loud.
I don't know that I would call some of the ones that are talking schools. I think that whenever you have people that spend a lot of time studying, doing research, and clinical work, etc., there is a lot of agreement and very little disagreement, right? So if you take the ones of us in academia that also do clinical practice in some form, I mean, I have the foundation clinics, and then we do clinical trials, and there's not a lot of disagreement. The disagreement comes more like at the media level, right? There are some loud voices, and the loud voices pick a couple of papers, and they think that those are enough to come up with it, or they may have a wrong interpretation of something, and yeah. So I think that what we do with prostate cancer patients, right? So we follow a number of prostate cancer patients, is to try to solve it all, right? So we want them to keep lean body mass. We want to keep IGF-1 relatively low, but we don't keep it too low. We want to keep glucose low, but we don't keep too low. We want to keep muscle strength. And so we want to do everything that makes it difficult on the cancer. And so if you give people 1.4 grams per kilograms or 0.7 per pound, if it's animal-based, you're going to have a lot of amino acids and a lot of IGF-1 that makes it easier for the cancer to grow, right? Makes it easier for the testosterone to be high and makes it easier for the cancer to grow. Now, it is true, if you go to the other side, whether, and we see it all the time, and you become frail, then you got the opposite problem. Now your immune system becomes weak. And now it doesn't matter, maybe your IGF-1 will go so low that now the patient is in worse trouble than if he was taking more proteins and more. Yeah. So I think it's a very difficult job, right? That we do. And it took us a long time to get to the right place, but yeah, all of it has to be achieved, and it's not easy, right? But I think that also I would not think about proteins, but I would think about amino acids, and about amino acid composition. And so it's really about amino acids, and it's about following with DEXA, following the lean body mass, follow, let's say, grip strength, and so if the patient is doing good and is stable, then that's good, right? So I always complain, for example, in our trial in Genova, Italy, we had a big discussion with the physician about proteins, and so the physician recommended a Mediterranean diet with so the patients were hormone therapy, and they were doing a fasting mimicking diet cycle once a month, right, during the hormone therapy for breast cancer trial. And so the argument was, we say keep it 0.8 per kilo, so 0.37 per pound, right? Keep it 0.37 per pound, good quality, meaning like amino acids, not too many legumes, so fish plus plant-based with high, essential amino acid levels. But the physician said, no, I'm going to go twice as much, right? So 0.7, 0.8. Yeah. And so the problem that what we saw was that the patients, the women, were actually gaining muscle mass. And we thought, this is terrible, So there's no reason. And we give them also training exercise as part of the trial, right? We had a video, and we showed them the video of the muscle training they had to do. And so we thought there was no reason to make him gain muscle, right? All we had to do is keep the muscle. So we could have lowered it to 0.37 as we had asked. Keep the muscle and then go after the cancer. Keep the strength, keep the immune system. So we are monitoring everything, of course, white blood cells, lymphocytes in particular, et cetera, et cetera. So if red blood cell, if everything stays well and the muscle is good, then go as low as possible without going into malnourishment. So don't go past 0.37. So that was the way to go. We lost that fight, and we were very upset when we saw that, they were gaining weight. There's a Schwarzenegger women, right? So there was no reason to make him gain weight, but go after the cancer and not the, why, right? They were not in a situation where they needed to gain muscle mass.
What's the problem with gaining more muscle in people or in that study?
Because the only way you're going to do that is by having high IGF-1. And what is the number one factor that we see in the mice and in lots of epidemiological data to promote cancer and double, right? Cancer growth and blocking cancer apoptosis, right? So this is the perfect growth factor that you don't want to have very high, because it's going to do two things that you don't want: help the cancer grow, but worse so, help the cancer stay alive, right? So that you're treating cancer patient, maybe one cancer cell left, right? And if there's a lot of IGF-1, they may very well protect that cancer cell that is going to become now your recurrence.
Yeah, so we do know, I think my audience knows that IGF-1 is one of those biomarkers that you want to kind of look at consistently, which honestly I look at all the time. And unfortunately, urology is not looked at all. I call that a part of the microenvironment, right? Part of the tumor microenvironment, and IGF-1 is one. What's a good range, in your opinion, that that you want to keep your IGF-1? What's an optimal range in someone who's interested in either preventing cancer, or which I assume is everyone, but maybe they're at a high risk, or they already have cancer and they want to keep it at a good range? What's that number? Do you know?
Yeah, no, I know, because we actually did a meta-analysis on this, right? So we published it a few years ago in Aging Cell, and it's 120 to 160. So that's the range that we saw at the, this was mortality, it was not cancer, but I mean, we think that probably that 120 to 140 may be a very good range for a cancer patient, just to make sure that everything is okay. We don't like it when we see IGF-165, right? And we certainly don't like it when we see 280. So if you see 120 to 140, that seems to be ideal. And also insulin should be low, and glucose should be low. Yeah. And so those three things are the ones that could certainly help cancer stay alive. But also those are the things that if they go too low, they could go after the immune system and just make your system less able to fight cancer. And that's the worst, right? Yeah. If your system shuts down and you're frail and it stops, the immune system stops fighting the cancer, then you got an even bigger problem.
Fascinating. So I'm just processing so much information now. Is there an insulin range that you have studied to be like you have studied the IGF-1 that you'd like to see in patients?
I mean, I would say the lowest in the acceptable range, right? The lowest it is. So the more insulin sensitive you are, the lowest the insulin is. And the lower, so if you can keep glucose, let's say glycemia from, let's say 70, 75, that range, that's ideal. That's going to make it more difficult for cancer cell to stay alive. And it's not going to get you into a hypoglycemia state and some weak state where the immune cells are going to suffer. So usually we try to get patients to stay, let's say 70 to 80 range of glucose without high insulin, right? So we do not want that the patient has high insulin, because insulin can drive not all cancers, but insulin can help a lot of type of cancers stay alive as IGF-1, right? So if you have all three down, then I think that one of the three is going to be very important for that cancer to grow.
Does fat? So when we, food doesn't come in isolation. So it's not like one can eat. Well, you can, but it takes a lot of work to eat just protein. So if you have a steak, depending on the type of steak, that steak can have a lot of fat. So do we know that the fat is also not triggering a high IGF-1? So if I have 100% lean steak, no fat, which is almost impossible, but let's just say that the fat is also triggering IGF-1, and maybe, or do we know that is the amino acids that in the protein?
It's mostly amino acids, and it seems to be probably a component of sugars, right? So sugars and amino acids, those are the ones driving the growth. The fat does not. Fat is associated with fasting states and no need to grow, right? So fat. This is why the FMD is a high fat diet. So fat gives the signal growth is not necessary. Let's focus on maintenance. But when amino acids and certain amino acids are high, and glucose, but especially amino acids and proteins, that's when you see IGF-1 go up.
Yeah. I think you published a recent study on kidney disease and FMD. Would you like to talk about that a little bit?
Yeah, so we just published this in collaboration with Laura Perrin at the Children's Hospital in Los Angeles. And, this is a really remarkable study, I think, because it looks at, first of all, it was the first time we did we look at fasting mimicking diet in rats. And so we came up with a low sodium version of the fasting mimicking diet. And then we did the permanent damage or long-term damage to the rat kidney, and then started the cycles of the fasting mimicking diet. And it's really something remarkable, because you see, and we did something called spatial transcriptomics. So you get to see how different genes, the expression of different genes change in different cells. And so basically, you see that the rat kidney gets damaged, badly damaged, and then you do the fasting mimicking diet cycles, and almost like magic, it goes back to its normal state, right? So it means that as we had predicted for lots of other organs before, the fasting mimicking diet and feeding cycle are able to trigger this developmental like program that rebuilds or reprograms the kidney into a younger and healthier state. And so this was rats, and you could see we could reverse the damage in the rats. But then we did the same in people. It was called randomized crossover, small one, 7 patients in one arm, 6 patients in the other arm, but then all 13 did the fasting mimicking diet. And these are kidney damaged patients. And not only they show improvement in proteinuria and other markers of kidney damage, but 1 year later, most of the people that gained the changes after just 3 cycles, they maintained the changes, right? So this was really, of course, we need a much larger trial now, but very good start, especially because almost identical results were seen after the first 7 people did the 3 cycles, and then the crossover, the 6 people, they crossed over and they did the 3 cycles themselves, and we saw again the same results, right? And these were accompanied by about a tripling of what's called kidney progenitor cells in the blood. So in circulation, there were these cells that are known to be causing generation or regeneration, right? So this was really interesting because, all of a sudden in circulation, it's almost like if the stem cell somewhere else were activated to assist the kidney into repairing itself. So they send progenitor cells. I mean, speculation, we don't know. But based on what we saw in the rat and what we see in the mice, I mean, it's a reasonable speculation.
That's fabulous. Dr. Valter Longo, I've had such a good time in this conversation. I would like to, at some point, invite you again, maybe in sometime 2025. I think my audience, particularly in the world of prostate and prostate cancer, they want to hear from you. They love your work. They love FMD, or at least those that know about it. I think way more of them will know about it now. So thank you so much for being on. Please, final words, and how can people find more about you or fasting mimicking diet?
Yeah, so Instagram, Professor Longo, or, I think it should be easy to find. Longevity Diet is the book. The new book on cancer is coming out. It's called Fasting Cancer. It's coming out, I think, February 5th. And we'll be happy to send you a copy. And I think it's on pre-sale right now. And it's got a chapter on prostate cancer. So I encourage you. I mean, I don't make a penny out of it. All of it goes to the clinics. And the clinics then come back and help people with prostate cancer and other cancers, sometimes for free if they cannot afford it. So I think that those are the places that allow people to follow what we do.
Wonderful. Anything that we missed that you like to touch on before we go? Any important point?
No, I think
we covered it.
We covered it.
Thank you so much. I'll link up everything that I have here. And please, send me a book. I'll give you that information once we're off. Thank you so much.
Thank you. Okay. Bye.
All right, everyone. Thank you so much for tuning in to this yet amazing episode of the Dr. Gio Prostate Podcast with the one and only Dr. Valter Longo, who talk about science-based. This is all science. If you can't prove it, it's sort of like we don't do it kind of approach, and I can appreciate that. So I know you enjoyed this particular episode. Thank you again for being on. There's always more, so stay tuned, and don't forget to go to the drgio.com, and there's a lot of resources there, and sign up for a weekly newsletters. Again, I'm always trying to give you all the things, all the tools you need to empower yourself as a self-health advocate. Much love, and I'll see you next time. Be well. Thanks for tuning in to this week's episode of the Dr. Gio Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.